At the outset, I would like to thank organizers for giving me this opportunity to talk on this topic. Mm. After all neoadjuvant and surgical and radiation topics, there comes locally advanced stage 3 non-small cell lung cancer we do commonly see in our routine clinical practice. So just a quick introduction. The burden of lung cancer is huge, stands second most cause in males. And management of unresectable stage 3 non-small cell lung cancer is definitely a multidisciplinary approach. As you can see, surgeons, thoracic surgeons, pulmonologists, medical oncologists, radiation oncologists, and pathologists combined together will take a decision. A lot of diagnostic and pre-treatment evaluation happens, including pulmonary function test, bronchoscopy, FDG PET, and pathological media and lymph node evaluation and brain MRI. So definitely concurrent chemoradiation is a standard of care for stage 3 unresectable non-small cell lung cancer. Concurrent chemoradiation is superior to sequential chemoradiation. We saw a previous speaker saying that. A lot of chemo regimes have been used along with radiotherapy in non-small cell lung cancer. I don't want to repeat the same thing, it's already been discussed. So the unmet need in stage 3 non-small cell lung cancer, even with concurrent chemoradiation given as a curative intent, the 40% of local regional metastasis happens, and there is a 50% distant metastasis with a median PFS of 8 to 12 months and the 5-year overall survival of 15 to 25%, which is not enough. Something has to be done more. So there is a lot of attempt to make it better. So various trials have been conducted to evaluate consolidation therapy with a very modest benefit, and no phase 3 studies of consolidation with chemotherapy, a target therapy, or vaccines have demonstrated a PFS or a OS benefit in these patients. So if we can see this evolution of treatment approach way back to 1960s, RT alone, then came sequential chemoradiation versus RT and concurrent chemoradiation, which we discussed with a no OS benefit. So how to improve the this subset of patients? So there has been concurrent chemoradiation to be considered as a standard of therapy for patients with good performance status, while sequential CRT remains an option for patients with a marginal performance status. To improve prognosis further, strategies like increasing radiation dose, induction chemo, consolidation chemo were evaluated in addition to concurrent chemoradiation, with no significant improvement in OS was seen with these. So immunotherapy is increasingly being recognized as a safe and effective option as an adjunct to concurrent chemoradiation. So this is our first phase 3 randomized double-blind placebo-controlled multicenter international study, specific study design. Patients with stage 3 locally advanced unresectable non-small cell lung cancer who have not progressed following definitive platinum-based concurrent chemoradiation, 18 years or older with a good performance status with an estimated life expectancy of more than 12 weeks, were randomized on a 2:1 fashion. In experimental arm, Durvalumab 10 mg per kg 2 weekly for up to 12 months, around 470 odd patients, and another arm, placebo at 10 mg per kg 2 weekly for up to 12 months. So the radiation and the starting of the treatment, the gap of 1 to 42 days was seen in the study. The primary endpoints, PFS by BICR, and overall survival. The key secondary endpoints like overall response rate, duration of response rate has been measured. So these are the baseline characteristics. As you can see, it's well matched for age, sex, race. And in this study, there are around 50% of the patients in 3A and around 45% in 3B in both the groups. If you can see the EGFR mutation status, around 6% of the patients were EGFR positive, but this was not the primary priority of the study, but it was analyzed. So the PD-L1 expression levels were also taken into consideration, but again, this was I'll tell you when I come to the post-hoc analysis. So the PD-L1 expression, TC less than 25% was seen around 40% of the patients in Durvalumab arm and 45% in placebo arm, and TC of more than 25% in 24% of the patients in Durvalumab arm and around 18% in placebo arm. So smoking, current smokers around 17%, 16% in Durvalumab arm and 16% in placebo arm. So nearly almost 27% of the patients received induction chemo with variable regimes. So all patients received 2 or more overlapping cycles of platinum-based chemotherapy concurrent with RT. So patient may have received prior chemotherapy in more than one context. Majority of, that is 99.7% had received concurrent chemoradiation prior to the study start. Had received induction chemotherapy. So these are updated 5-year overall survival in intent to treat population. So as you can see, around 43% of the overall survival rate of 43% was seen at the time cutoff of 5 year versus 33% in placebo. Is something very overwhelming in so-called unresectable stage 3 lung cancer. So this is the first and only approved IO to demonstrate 42.9% of OS at 5 year. So this is the updated progression-free survival in blinded independent central review in intent to treat population. So you can, as you can see, the PFS rate of 33.1% versus 19% at 5 year follow-up. So this is again a first and only approved IO to show sustained and durable PFS of 33.1% benefit at 5 year. So if you see the first subsequent therapy after discontinuation of Durvalumab, even in Durvalumab arm, 41% of patients and 54% of the patients in the placebo arm received a subsequent disease-related anti-cancer therapy. That means the subsequent therapy, progression was also reduced even in spite of discontinuation of Durvalumab in this study. So systemic therapies were the most common first subsequent anti-cancer treatments in both Durvalumab and placebo arm. But as you can see in the Durvalumab, it was 33% and it was almost 13% more, that is 46% in placebo arm. Even if you see the patterns of disease progression, as you can see in the left side, Durvalumab intrathoracic progression is seen around 36%. And if you see in the placebo, it is around to the tune of 48%. If you see the extrathoracic lesions, it is around 7% in Durvalumab arm and almost nearly double, that is 13% in placebo arm. So new lesions identified within the lung parenchyma or generally chest wall, including the diaphragm, were categorized as intrathoracic, where all the other lesions are categorized as extrathoracic. So intrathoracic progression was the most common in Durvalumab arm versus placebo, that is to the tune of 80% versus 74%. But reduced rate of first progression was seen in Durvalumab arm, that is 45% versus placebo, that is 64% of the patients. So the time to intrathoracic progression only or death as per BICR, the Durvalumab improved the time to intrathoracic progression when compared to placebo. It is the median time was 25.2 months versus 9.2 months in placebo with a hazard ratio of 0.55. So there was a reduction in new extrathoracic lesion which was seen in Durvalumab arm. It is around 8% at first progression versus placebo, which is almost double, like 16.5% in intent to treat population. And approximately 2/3 of patients had 1 or 2 extrathoracic lesion at first progression in subpopulation with progression. Even the number of lesions, if you see in the Durvalumab arm, the number of lesions and the progression to the number of lesions were less compared to placebo arm. So this is a safety summary. Grade 3 or 4 side effects were seen in around 30% of the patients in Durvalumab arm, which is slightly higher compared to placebo. So this was the French study to see when exactly you need to give Durvalumab after concurrent chemoradiation, because a lot of discussion happened about pneumonitis. So what they have done in that specific trial also, the patient should have resolved pneumonitis or at least not more than grade 2 pneumonitis. If the patient has more than grade 2 pneumonitis, then those patients are not actually eligible for the Durvalumab study in a specific study. So this is another French study where they analyzed around 591 patients enrolled with the Durvalumab versus the placebo. So this is the baseline characteristics, which is very similar to the Pacific trial actually. So in this study, around 78.5% had a partial response, 15.2 had stable disease, and 6.3 had CR. So the median interval between the end of concurrent chemoradiation and effective initiation of Durvalumab was actually known in 161 patients in this French study. So around 2.5% of the patients received Durvalumab, started Durvalumab less than 2 weeks. And majority of the patients, that is around to the tune of 58% of the patients, they had the Durvalumab between 14 to 42 days. Whereas more than 42 days, around 40% of the patients were started beyond 42 days of completion of concurrent chemoradiation. But what they found out in this study was the responses were like what was observed in Pacific study, despite almost 40% of the patients received Durvalumab 42 days after CRT. So the concept that we need to hurry up in starting the Durvalumab immediately after radiation may not be possible in many times, because patients recovery from pneumonitis, patients has to recover from the concurrent chemo radiation toxicities. In certain cases, you can actually wait up to 30 to 40 days in starting the Durvalumab. That is what they have shown. So the 5-year survival is important endpoint. Optimum concurrent chemo radiation followed by IO should be the standard of care in all standard 3 unresectable patients. And converting stage 3 lung cancer into a never progressing disease is an ideal dream. So the key take-home message is Durvalumab demonstrated a statistical significant clinical meaningful improvement in OS and PFS versus placebo in this specific trial. The median OS was 47.5 months for Durvalumab versus 29.1 months for placebo with a hazard ratio of 0.68. The median PFS was 16.9 months with Durvalumab and 5.6 months with placebo with a hazard ratio of 0.51. OS and PFS improvement with Durvalumab was demonstrated across all pre-specified subgroups. The 5-year overall survival rate was almost 43% of patients randomized to Durvalumab remain alive at 5 years compared to 33% in the placebo group. A third remain both alive and free of disease progression in Durvalumab arm, demonstrating OS benefit and PFS benefit in this specific regime. Patients receiving Durvalumab had a lower incidence of new lesions, including new brain metastasis compared with patients receiving placebo. Tolerability profile of Durvalumab was acceptable. Low-grade pneumonitis is not a deterrent to use Durvalumab. And as I showed you in a French study, Durvalumab was started beyond 42 days after CRT and showed similar responses to the ones observed in Pacific data. Thank you. If any questions, I would like to.